So today we're going to talk about the ED workflow. A not uncommon scenario in the emergency department is you may get a patient who maybe isn't the best historian and at the same time may also have multiple chief complaints. So when this happens, you may begin with your chief complaint, your history, and kind of get thrown around and kind of diverted into many different directions. And as a result, 20 minutes, 30 minutes, 40 minutes may go by, and you may not have a clear idea as to what exactly is going on or what direction your initial workup and resuscitation needs to go in. So what we're going to talk about today is an approach to your patient that varies a little bit from how you learned in med school, but will allow you to more efficiently figure out how to work up and treat your patient. So let's get started. So in medical school, we're taught to approach a patient as follows. We start with a chief complaint, we move on to the history and the physical, after which we figure out what our differential diagnosis is, and from there we determine what are the appropriate labs and imaging that we need to order in order to work up our differential. We then initiate a treatment plan and finally a disposition plan for our patient. So this is great if you have a lot of time to spend with your patient. However, in the emergency department, you want to be able to figure out what labs, imaging, and treatment that you need to initiate on your patient within the first 20 minutes. Figuring out what to do in 20 minutes is really important because your main goal is to try and dispo your patient within 4 hours. So what we recommend is to take your differential diagnosis and to move it to just after your chief complaint. Now, this isn't just any average differential. This is going to be your critical differential diagnosis. You want to think about the 4 or 5 deadly differential diagnoses that your patient could be having based off of their chief complaint. So for example, if your patient was having chest pain, the differential diagnosis for that would be ACS, pneumonia, pneumothorax, aortic dissection, and pulmonary embolism. So now that you're armed with this differential diagnosis, you can ask much more precise history questions and perform a much more focused physical exam to make sure that you're not going to miss something potentially life-threatening on your patient. So going back to our chest pain example, you may want to ask historical questions like, did you have pressure substernal chest pain that radiated to your left arm? Have you been having any fevers or a productive cough? Have you had any recent trauma or a history of COPD or asthma? Is the chest pain tearing, ripping, and radiating to your back? Have you had any recent foreign travel or immobilization of your legs? It's important to remember that you're not going to stop your history and physical exam at just these 5 diagnoses, but it's a good starting point. So as you march down the history and physical exam, your patient may present with a wild card. For example, they may be immunocompromised or be on a blood thinner. So when that happens, you can reassess your differential diagnosis, cycle back, and begin to ask more focused history and physical exams that may pertain to that specific wildcard. And you would essentially keep cycling through this until you have an appropriate differential diagnosis, at which point you can then fire off your labs and imaging. The benefit of this approach is that if your patient has 2 chief complaints like chest pain and abdominal pain, you can immediately construct your differential diagnoses for both the chest pain and the abdominal pain and have a much more focused history and physical exam as you try to figure out if there is some association between the 2 chief complaints. Also, by reassessing your differential diagnoses after your physical exam, you'll prevent early anchoring, which means that you won't prematurely close your workup for this patient because you'll constantly be thinking about whether or not you're missing an important differential. So again, your whole goal is to try and get in and out of your patient's room in 20 minutes with an appropriate differential diagnosis and a clear vision as to what labs and imaging you need to order, what treatment you need to initiate, and what direction the disposition of your patient is going to be. Now, when you're presenting this patient to your attending, you do want to follow the traditional formula of chief complaint, history, and physical exam. After your physical exam, you want to jump straight into your assessment and plan, and in that start with your critical differential diagnoses. By doing this, you let your attending know that you have not overlooked something that could be potentially life-threatening. So for example, we can go back to our chest pain patient and we could say, for our assessment and plan, we have a 54-year-old male who presented here with chest pain. My critical differential includes ACS, pneumonia, pneumothorax, aortic dissection, and pulmonary embolism. From there, you can go on to discuss why you either think they have one of these critical differentials or why you don't think they do. And from there, you can determine what are the appropriate labs and imaging that you need to order for this patient to adequately work them up. And that's about it. So I hope this helps with your initial assessments of patients in the emergency department and will help facilitate a faster ED workflow.